webinar for the American Academy of Pediatrics. This is our 10th session, and I am going to turn it over to Kristen.
Hi, and welcome. Some teleconference reminders, just to keep your phone on mute while you're not speaking, and don't put it on hold, please. Our objectives for today are introductions, presentations from AFMC and Qualis, and Q&A from each, metrics for 2015, and process and variation from Dr. Kuo. And then we'll, if we have time, we'll end up with some questions. Support is provided by Arkansas Medicaid, and we can do a quick roll call. However, I can see who's on the line, so it's probably not necessary for today. So, Rolinda, if you would like to start your presentation from AFMC, that would be wonderful.
Sure, thank you, Kristen. So, would you like me just to say advance the slides?
Yes, that'd be great.
Okay. So, good afternoon, and thank you for taking time out of your day to allow us to offer information regarding AFMC's PCMH Practice Transformation Services. Next slide, please. So a little history about AFMC. Arkansas Foundation for Medical Care was founded in 1972 and has been dedicated to improving health care for Arkansans since then. Some of the milestone dates that we have encountered, you can see here, since the early 1990s, AFMC is focused on quality improvement and transformation of healthcare landscape for our state. We are Arkansans serving Arkansans. In 1996, the catalyst for the transformation for the PCP, Primary Care Case Management, PCCM system, which was the first basic medical home opportunity in Arkansas, and AFMC executive staff served on the Governor's Committee to establish the PCCM, and together with quality improvement efforts, the PCCM paved the way for adopting transformative healthcare change in Arkansas. In 1997, the AFMC Medicaid Provider Relations Team was developed to provide education and technical assistance to Medicaid provider community across our state. Since 2003, AFMC has served on the Arkansas Department of Health as the Quality Improvement Advisor for the Arkansas Clinical Transformation Collaborative, which was formerly known as the Arkansas Chronic Illness Collaborative, and has been actively involved with the planning committee and faculty for the collaborative learning sessions. AFMC has provided individualized assistance to practices in transforming their journey and identifying best practices to share with participating providers and providing content expertise during collaborative learning sessions. In 2004, AFMC was one of 4 states to participate in the Doctor's Office Quality Information Technology, our DOCIT project, which was a 2-year pilot study by CMS, which was designed to improve the quality of care for patients with chronic disease through promotion of and adoption of EHR and health information technology. 2006 began the Physician Voluntary Reporting Program, PVRP, which began with a set of 16 core clinical quality measures. AFMC has worked with providers across the state to ensure accurate capture of data in an ongoing effort to measure and monitor quality of care provided. AFMC continues this effort today under a program identified as PVRP to what is now known as PQRS, the Physician Quality Reporting System. It is an ongoing effort that uses a combination of incentive and payment adjustment to report clinical quality measures for eligible professionals. Efforts for the 2013 year proved that AFMC was one of the highest-ranking states in the nation for increasing submission of data to CMS in both claims and electronic reporting. Efforts for 2011 submissions, AFMC was shown to have increased submissions by nearly 500% for our state. In 2007, the Medicare Care Management Performance Demonstration, MCMP, was a 3-year pilot program as part of the Medicare Prescription Drug Improvement and Modernization Act. 150 practices across the state voluntarily participated with AFMC providing technical and transformative assistance to report clinical quality data and meet clinical performance standards. Participating practices were provided the opportunity to earn additional incentive dollars through this program when they demonstrated the improvement utilizing practice redesign processes to improve quality of care through electronic reporting of data. The program was successful in showing that providers that clinical transformation was vital to their patients receiving the right care at the right time and earned these providers in Arkansas over $1 million in incentives. In 2010, AFMC was designated federally by the ONC to be the Regional Extension Center for Health Information Technology and was tasked with assisting 1,280 primary care providers with the adoption and implementation and meaningful use of certified EHR technology. Over the last 4 years, AFMC has supported more than 1,500 Arkansas primary care physicians. In 2014, as part of a restructuring of the Quality Improvement Organization program to create a new approach to improve care for beneficiaries, families, and caregivers, AFMC serves as the QIN-QIO for Arkansas, working under the regional umbrella of TMF Health Quality Institute, along with Missouri and Oklahoma. We continue to work with providers, healthcare facilities, clinical practices, and communities throughout the state to drive quality. Your AFMC Practice Transformation Team has a broad knowledge of multiple initiatives and knows how valuable a provider's time is. Next slide, please. AFMC's Practice Transformation Team is a multidisciplinary team full of employees based across the state. The team is comprised of members with vast experience in both adult and pediatric primary care. The team includes nurses, office managers, financial officers, billing and coding professionals, compliance officers, EHR vendor liaisons, and certified experts in meaningful use, HIPAA privacy, quality improvement, public health, in both inpatient ambulatory EHR systems. The team's knowledge and skills encompass many facets of the healthcare continuum, including experience with over 10 different EHRs and healthcare information systems. Additionally, the AFMC team members' credentials include training in the National Committee for Quality Assurance, NCQA, PCMH content, including the concepts of the medical home and medical home transformation. We have 38 AFMC employees who are trained and eligible to sit for the NCQA, PCMH, CCE exams. Team members have a minimum of 10 years hands-on in the trenches experience in a practice setting. Your team will be comprised of individuals who not only work with you, but live in your communities as well. Next slide, please. So what can you expect as a minimum from AFMC? You can expect a minimum of 30 hours of support. You can expect up to 65 hours of support for large practices. You can access a members-only online learning community. You can expect monthly on-site visits with your transformation team. You can expect quarterly learning collaboratives and networking opportunities. You can expect a practice assessment and tailored implementation plan. And you can expect us to align our efforts with other initiatives, both state and federal. Next slide, please. So in more detail, PCMHs will receive a minimum of 30 hours of support per location if you need it. PCMHs will receive up to 65 hours of support for large practices per location should you need it. And large practice for us is defined as having more than 5 providers. The support that you'll receive during this would include defining your PCMH roadmap to track and monitor your progress, assistance in identifying high-risk populations, assistance in monitoring of your high-priority beneficiaries, along with your total patient population, the development of a plan for monitoring activities and metrics and your quality on a regular basis to ensure your PCMH success. You will also receive education and monitoring of your care plans. Through the members-only learning collaborative, you'll have access to vendor-specific forums and user groups. You'll have a collaboration area for sharing of best practices or issues. You'll be able to access any recorded presentations and videos along with our tools. Through the monthly on-site visits, you can expect in addition to your weekly contact by email, phone call, or virtual visit. Your quarterly learning collaboratives will offer networking opportunities for all of your PCMHs participating with AFMC. Your practice assessment and tailored implementation plan will be created for each PCMH practice. But to avoid provider fatigue, we will align with other state and national incentive programs to minimize the burden on providers and their practices. This will include other qualified health plans as they roll out their PCMH programs. We will align with efforts for practices who want to seek NCQA certification as well. We understand that each of your practices is unique, and each will require unique approaches to be successful in the PCMH program. We strive on all levels to align the efforts of the many programs and minimize the burden on your practice. We've been transforming Arkansas practices for over 40 years and are committed to keeping complex processes as simple as possible and minimizing the burden to you. For you as a provider, knowing that should you have an emergent issue or an issue in general, your practice transformation team is just around the corner and readily available for you. The success of Arkansas physicians is a personal issue for us. Last slide. So, Kristen, do you want us to take questions now or at the end?
I think that it might be best if you each took your own set of questions. So if you want to take them now, that'd be great.
Okay. That would be fine.
Okay.
Are there any questions? No questions at this time?
Well, I do have one.
Okay.
This is Dr. Patton over in East Arkansas, and one question I had for Ms. McFadden is if a practice signs up with, does not sign up with AFMC, are we excluded from participating in some of those online learning activities?
Yes, sir.
Okay.
Those are specific to the providers who sign up with Arkansas Foundation for Medical Care.
Okay, thank you.
Thank you, sir. Any other questions?
Okay, if no one else has questions for Belinda, thank you so much for your presentation, and we will go on to hearing from Rhonda Hill and Trudy Bearden from Qualis.
Thanks, Kristen. This is Rhonda. Can you hear me?
Yes.
Great. Welcome, everyone. Myself and co-coach Trudy Bearden are here with you today. I'm going to give you just a brief introduction of Qualis Health and of myself, and then I'll pass a slide set to Trudy. She'll do a couple of slides as well, and I'll have her introduce herself and her background when she speaks. So again, my name is Rhonda Hill. I'm here in Arkansas. I live here and I've worked in the healthcare system over 10 years in the state. I have worked with the Qualis team in 2014 as we were the selected practice transformation vendor to support the PCMH Medicaid program last year. So we worked with over 71 Arkansas practices, over 100 Arkansas locations. And through that time, we provided not only on-site support to practices in their offices, and we also provided in-person workshops where folks would come together, learn about topics of interest, topic of need related to the Medicaid PCMH program, have opportunities to network with other clinics, brainstorm about challenges and solutions regarding the program, and creating efficiencies in your practices. We also offered online webinars, topic-specific, over the course of the 12 months, things like how to budget appropriately for using your PCMH dollars, empanelment of patients, so making sure your patients and providers know who one another are and that you know who your panel of patients are, care coordination, meeting the metrics of the patient-centered medical home, items like that. Additionally, we offer many interactive tools and resources that are only available, just as Merlinda noted, the resources and tools that Qualis has to offer are also only available to those folks who sign up with Qualis Health. So same-day tracking tools, tools to ensure that you're meeting your 24/7 access requirements, care coordination planning, lots of different things that I can actually talk about later as we walk through the presentation. On a national basis, I just wanted to also highlight that Qualis Health is a nationally recognized leader in PCMH transformation. We've supported thousands of practices across multiple states over the past several years. One of the things we hear a lot from practices in our work is that they need a lot of assistance with workflow redesign. So taking pieces of the current day-to-day operations of your practice, identifying where efficiencies or improvements may need to be made, and then redesigning how you get from step A to step B. So we call those workflow redesign workshops. We've led over 85 in the past 3 years, and we plan to bring those workshops into the Arkansas PCMH program this year as a new offering for our practices. We've got a lot of national connections, including our coaches who are NCQA certified and are willing to assist the practices here in Arkansas if they have that need for NCQA certification. I'm going to transfer it to Trudy. She can introduce herself and fill in any other information that she wants on a national basis if you have anything to add, Trudy. And you can go to the next slide, Kristen.
Thanks, Rhonda. I'm Trudy Beard, and I'm one of the PCMH coaches. I'm the technical content lead on this project. I am a clinician, I'm a physician assistant, and I practice in the rural family medicine arena. So what I see in the practices in Arkansas is very similar to my practice as a rural family medicine physician assistant. What you're looking at now are the change concepts for practice transformation, and this is the framework that Qualis Health bases their practice transformation work. And even though we focus on the Arkansas Payment Improvement Initiative metrics and activities for support, this is always in the background, and we found in our experience with 2014 that all of the practices experience either struggle or successes in each of these. For example, in engaged leadership, some of our sites struggled with getting buy-in for the Arkansas Payment Improvement Initiative, getting folks on board for doing those care plans, making sure everyone knew about the program. Sometimes we found that the decision to participate in the initiative was made from above and then not communicated adequately to the rest of the staff. And so we're working on a communications toolkit for 2015 that will help ameliorate some of these issues. We've also found that having some sort of sustainable quality improvement strategy in place is key for practices to improve their metrics for support and for their shared savings. And we've consistently found across many, many initiatives and collaboratives that practices that don't routinely measure and review their performance are unlikely to improve. We were so impressed with one of our PCMHs that had posted run charts of all of the ABII metrics all over the clinic. They were really a shining star. Empanelment, we worked a little bit on empanelment. Within the context of the APII, we had one practice that cleaned up her, the lead cleaned up her practice, patients. They had had their EHR in place since 2008, and she remarked one day that cleaning up your panels will help with everything, apparently. Additionally, we connected UAMS with one of our pediatric residency practices at Boston Children's Hospital so that they could also learn about empanelment and the struggles that they've had in a residency program with empanelment. Team-based care, even our rural solo doc offices have benefited with guidance around team-based care, having everybody work at the top of their licensure and bringing joy back to the practice. Organized evidence-based medicine, you know, practices just get this. There's just not a lot of work to do other than getting some guidelines in place. One of our practices did a really great job of establishing what the screening guidelines were, and then they tapped into Amy and were able to really track and reach out to their patients who are due for preventive care. Patient-centered interactions, this is usually the last puzzle piece that falls into place. but our Arkansas practices are doing really creative work around this. We have one PCMH lead that just goes into the waiting room and talks to patients about their experiences coming to the clinic and how the clinic might improve that experience. They don't need to do fancy surveys that they mail out. They really reach out to their patients to find out how they can improve their practice. Enhanced access. Oh boy, did we see a big change in 2014. At the beginning of the year, very few practices had support in place for their patients when they called in the off hours, and now pretty much everyone has that. I've called practices and heard the voicemail messages after hours, and it's just incredibly encouraging to hear. Care coordination, separate of course from the CCNC work. A lot of our coaching is centered around reducing barriers to care. We've provided referral agreement templates, resources, sample job descriptions for care coordinators and care managers. We've helped practices develop their policies and procedures around closed-loop referrals and tests, including looking at their workflows to ensure that no balls are dropped and that all gaps in care are closed. So I'm going to move on. If we can move on to the next slide, I'm going to hand things over to Rhonda again.
Yes, this slide just calls out the services that we offer for 2014. So your practice is eligible for up to 40 hours of on-site or virtual one-on-one coaching. If your practice has more than one location, you are eligible for 40 hours per location. We've taken this number up since last year. We offered 30 hours per location last year. We've increased it to 40 hours this year, and we're really encouraging the practices that we work with in 2015 to think of us as a true extension of your workforce. If you have a quality improvement project or a task that you need to do that is related to improving the quality of the care you deliver for your patients or improving the work balance of the staff in your office, we want you to ask, and we want to be able to help with those types of requests. We offer a PCMH assessment, which really opens up a dialogue to gather just additional information and details about your practice and the opportunities to improve. From that assessment, we create a work plan that identifies things over time that we can continue to work on, as PCMH transformation is just a journey, and it's not a short journey, as you all well know. Online events, we offer live and online webinars. We have planned for once a month with different topics, several that are predetermined, several that we want to take stock of what you all have on your plates and what topics you would like to explore, and we'll develop those content areas as we go through the year. We have 4 in-person learning sessions or workshops that will be conducted similar to last year, and in addition, we have 4 additional training sessions that we will do out in a regional location, like the workflow redesign that I had mentioned earlier, focused on specific topics that you can apply to your practice. All of those events would be open to your staff, providers in your practices, and again, those would only be available to those practices that are enrolled with Qualis Health. And Trudy.
Thanks, Rhonda. So what does Qualis Health bring to the table? We have experienced PCMH coaches. Right before this call, I went and looked at our bio sheet and looked at all the years of experience that all of our coaches bring, and it's over 100 years of experience. And I was really flabbergasted by that. We do take a practical, hands-on approach. We encourage you to think of us as an extension of your workforce. For each location, you get 40 hours of coach time. That is a huge gift, a huge benefit that the Arkansas Medicaid provides to you through the Arkansas Payment Improvement Initiative. And last year we saw some practices take really good advantage of that time, and others, only went in dribs and drabs and an hour here, an hour there. And in 40 hours, we can accomplish a lot. And as long as things fit into the scope of the Arkansas Payment Improvement Initiative, there's no end to what we can help you do. We really focus on building highly reliable systems with accountability that are sustainable and are not just a Band-Aid that once the time and the support and the money from the initiative is gone, that things just dry up and go away. We want those changes and improvements that you make to stay there. And we also want to make sure that with those highly reliable systems with accountability, that it's not about everybody working harder and smarter, because healthcare is changing and that's no longer going to work. And, you know, we really have a reputation of providing practical hands-on assistance. Last year, honestly, we showed some people how to copy and paste. We helped install an Excel reader. We showed practices how to run pre-visit summaries out of their EHR. We even showed a practice how to print attachments from their email. There's no end to what we can and will do for our practices. And that's not just with this initiative. We will also try to tie whatever work you're doing into other efforts of your practice. If you're working on meaningful use, how can you tie that into your work with the Arkansas Payment Improvement Initiative? Looking at 2015, there are 3 critical meaningful use clinical quality measures that we're going to look at that are going to tie into your work. And we also have an army of experts behind us at Qualis Health, and we frequently call in reinforcements. We have several physicians on staff with extensive practice transformation experience, and we're thinking about how we can deploy those folks to help with some of the buy-in issues that we saw during 2014. So we'll really tailor our support. We have lots of tools to help you meet the requirements, and we can also help you with project planning and tying everything all together. Rhonda, I'm going to turn it over to you for our second to last slide.
Thank you. And just to call out some of the tools and resources that we have offered in the past year and plan to offer again, all of these resources, whether it's a document, a webinar, a recorded event, will all be posted on a secure site for the practices to access whenever they need them. Again, the change concepts that Trudy walked through, there are certain activities that are ideal that fit into each of those areas. So we've got a plethora of information on each of the change concepts, strategies to implement them, how to triage and target different challenges that you might meet with them, population health management, step-by-step guides on creating registries to better manage your population, use your EHR effectively to pull reports. We have many, many sample workflows that you could peruse and look through, trying to trigger things in your practice that might make sense to update. Huddle templates, we found that a quick 5 to 7 minute meeting in the morning prior to seeing your patients among your staff is helpful. So we have templates to walk you through quick questions on how to just glance at your patients, see that anyone has any care gaps that need to get filled that day. Maybe they're coming in for one purpose but have a well child check that could be finished or completed for another purpose. So you get those gaps filled and you're identifying those in the morning through a quick run through of your patients, things like that. As Trudy mentioned earlier, job descriptions that you may be thinking of as you expand your workforce or maybe retailor, repurpose some of your current staff into different roles that seem to better fit their level of certification and license, our PCMH assessment, and many more items. Kristen, the last slide is just our contact information. Anyone can reach out to myself or Trudy with more questions, or if you'd like to talk offline, we're happy to do that, as well as enroll with us for the 2015 year.
Thank you so much, Rhonda and Trudy. Does anyone have questions for either of them?
Yes, I have a question for Rhonda.
Yes.
Referring back to one of the slides, you said that there were physician consultants available if needed. Are any of those physicians in Arkansas, or are they all out of state?
They are currently all out of state, though we have access to them and they would be willing to consult with you as needed. And then we also have Trudy, who would be on site in a heartbeat as a physician assistant.
Okay, thank you.
You're welcome.
Other questions? Okay, well, thank you again, and I will turn this over to Dr. Kuo.
Great, thanks, Kristen. Well, good afternoon again, everybody. And I hope folks are enjoying the nice weather. I've got family up in the Northeast, and they've hunkered down, although it sounds like the blizzard went further east in New York, but I'm thinking, of course, of our friends in New England as well. I wanted to go over our metric changes for 2015. I have not actually seen final metric changes, but some of them are moving this year, or will likely move this year. And I presented some of this in the past, but I think it's a good opportunity to go over them and think about what we want to accomplish during 2015. Kristen, next slide, please. So a couple of months ago, we had proposed changes in the metrics circulated around the the PCMH work group. And the reason I think it's important to think about these metrics is because the metrics as they were originally designed were for us to get used to looking at metrics. Some of them are pretty general indicators of our overall delivery of care. And there was also a sense to make sure that these metrics were achievable so that we would be comfortable in participating and knowing that we can do this. Having said that, over time, of course, the intent of the PCMH is to improve care and continuously improve care as well as streamline the cost of delivery. And so in order to do that, the metrics will begin to move. And on this chart, I have put together a select number of metrics. The four metrics on top are the shared savings metrics, and the four metrics on bottoms are the practice support metrics. You'll have, I'm sure, remember the difference between the two when you look at your reports. And the reason these metrics moved is because when we looked at the when we look at the performance of enrolled practices over the space of 2014, they did pretty well. So accordingly, try to start to move our performance. Some of these metrics have changed. The target metrics will change in 2015. And what I have here are the last information I have is proposed metrics changes. We will see what the final ones are when they come out. Now, on the left-hand column, you'll see metric. The second column is the percent target that we were asked to achieve. The third one was the proposed target for 2015, and then the fourth column, the last column, is the range of what practices reported. And what I put on the last column, the range of what practices have been reporting or have measured over in our 2014 reports, that was information that was provided to us. What I did was take the liberty of looking at the ranges of practices that were clearly pediatric practices, and I posted the ranges here, obviously without any identifying information about who these practices are. So the first metric in the first row, you'll see ADHD, and that's the metric when we are asked to see children back within 30 days of initiating a medication for an initial ADHD appointment. So the metric was 25%. The proposed target for 2015 is 50%, but the range of practices was 25 to 53%. Now, most practices were actually up closer to 50. There was a couple of outliers either way. The second row is asthma, and that measures, you'll remember, is the percentage of children who have an asthma diagnosis and were prescribed appropriate medications through the year. The target for 2014 was 70%. The proposed target for 2015 is 85%. And you can see the range is 80 to 97%. So we had some practices that were in the 80% range, and there are some practices within the 97% range. So for this one, every single one of these practices met the 2014 metric. But if we applied the 2015 target, not all practices would meet this asthma metric. Looking at the adolescent wellness visits for adolescents that had a well visit within the last year, The target for 2014 was 40%. The proposed target for 2015 was 45%. The range of these practices between for 2014 was between 37 and 64%. Infant wellness, the target in 2014 is 67%, the target for 2015 is 70%, and the range was 61 to 87%. Moving down to the practice support metrics, care plans are proposed to move from 70% attestation to 80% attestation. As of the last report, which only pulled data up to about 6 months ago, the range was 0 to 51%. But I know of many practices that are continuing to enter them in, so that will rise. PCP visits for high priority beneficiaries, target for 2014, 67%, target for 2015, 75%, but the range was from 45 to 85%. 10-day inpatient follow-up, 33% in 2014, 40% in 2015. The ranges were 25 to 61%. And non-emergent ED visits. So the percentage of ED visits that were classified as non-emergent, the target for 2014 is 50%, and the target for 2015 is 33%. The range for 2014 is 19 to 25%. Are there any questions about this particular chart? Because it's got a lot of information on it.
Dennis, this is Cheryl
Yes.
Arnold.
Hi, Cheryl.
And we just have one comment on the adolescent wellness scores for 2014.
Yes.
It's that I think looking at that range may be a little misleading, because we may have had an anomaly last year because of the vaccine changes that impacted that age group, because we saw a very sharp upturn, and I would wait for a metric to be set based on a one-time occurrence, and it negatively impact practices because of the reason why it appeared so high in 2014.
Yeah, you know, Cheryl, I think that's a good point. Most of these metrics you'll find on national measures as well, and I have seen national Medicaid statistics for that measure, and the national the national rates for that particular metric is actually, for Medicaid populations, is somewhere around 40. It's actually closer to 39 to 40% on average. So there were a number of practices that did have that were up in the 50 to 60% range. There were quite a number that were around 40%, which was, again, regarded as the average. I think we just got to see how it shakes out. But I think you've got a very good point about that. Any other comments?
Dr. Quo?
Yes, sir.
This is Dr. Patton. I have a question about the 10-day inpatient follow-up. Is that metric measured only when the practice admits a patient and then follows up, or does that include patients, say, admitted at Children's and then need follow-up at our practices locally?
Right. My understanding, and I've practiced it numerous times, my understanding is this is any child in your practice that is admitted anywhere, but the child can also follow up anywhere.
I see.
So in other words, it's not specific to practice. It's specific. The child is admitted to Children's, but could follow up at Children's.
I see.
And if I hear anything different, I'll let you know. But that's something that I've had clarified a number of times. So I'm certain that is the answer.
All right. Thank you.
Sure. Any other questions? Okay, Kristen, next slide, please. So what this leads to is a little discussion of process and variations, and I'd like folks to think about how process and variation works. As we think about if we are in a situation particularly where we feel like we need to be able to move a metric from, say, let's arbitrarily say we've got a metric at 50% and we want to meet a 60% metric. The question I would pose to folks is, what do we need to do in order to ensure that we can get from 50 to 60% within a certain time period? And this is really what the industry uses as process control, and I think that the concepts, which I'll discuss for the next 5 to 10 minutes, is something useful for us to think about. Next slide, please, Kristen. So a process is a series of actions or steps that are taken in order to achieve our particular end. So if you, for example, have a well-child visit rate of 70% and you want to get it to 80% within the next 12 months, a process is the number of steps you have to take in order to get every child in for a well-child visit so that you can raise that overall target from 70 to 80%. In order to do that, however, you have to think about all the steps that you take in order to achieve that healthcare outcome, whether it is a preventive care visit or an immunization rate or proper asthma medications. You have to think about the process of the patient and family recognizing the need for a health supervision visit, the access to calling for a health supervision visit, your scheduled availability, reminders, transportation, and so on and so forth. So there are certainly a number of steps that you can take, some of which is directly under your control, some of which may not be, but you do have to think about those steps and think about what you need to do in order to be able to bring that process under control. Now, it goes without saying is that the more steps there are in a process, the more difficult it is to alter to achieve the outcome, because you just have a number more variables to consider. Having said that, that just reminds us that the more we simplify our process, the more reliable the outcome becomes. So, for example, if you rely on let's say that if you rely on 20 individuals to collectively remember a specific step, versus if you put a forced reminder within the workflow to make sure that all 20 individuals will remember that step, now you've actually cut down your process from 20 different items to one item because you put in a forced reminder or, say, a hard stop within an EHR. Next slide, please. So the ultimate question is, if you look at it purely from a metric standpoint, you have a metric that you need to meet. Can you predict that you'll meet that metric in time? Can you look at your process today and say, I can move it from 50 to 60% within the next 12 months? If you're not meeting this metric, what steps will you address to be able to meet this metric? And then how many steps do you have to address in order to be able to meet that metric? Now let's take this from just looking at it from a purely metric standpoint to a healthcare process and outcome standpoint. If you say, I want to be able to see my adolescents more often, the question I would say is, by the end of the year, how do we take the steps in order to make sure that we have raised our adolescent immunizations or our adolescent visit rate so that we can take better care of our adolescents? And we know at the end of the year that we have taken better care of our adolescents. Next slide, Kristen, please. In order to think about a process, there are two terms that I would like to discuss, which you'll hear over and over again when you talk about process control. Being able to get handle on a process and being able to meet a specific metric. And these two terms, which you'll see in quality improvement literature, is called common cause variation and special cause variation. And the reason these are important is because anytime you measure something, and as Cheryl has pointed out, for example, when you have an adolescent well-child visit rate of 50%, in one given month it could be 50%, and the next month it could be 70%, and the next month it could be 30%, and the fourth month it could be 45%. And then you're left to figure out which is the correct number. or is there a correct number? So I want to demonstrate something called common cause and then special cause variation. So common cause variation is natural variation that is inherent in a process. So every time you take a step, that step is slightly different than the step you took before. Every time you write a letter, it looks a little bit different than the letter you wrote before. So what you see here is when I was making these slides, I took a pen and I wrote the letter B, a capital letter B, and I wrote it 8 times. Now you can look at this and you can see that every single one of these B's is different, right? But you can recognize it as the same person's handwriting, right? So if you see that they're all slightly different, but they all look like they came from the same person, then this is common cause variation. It's a stable process. It's stable because one person with one hand wrote this several times in a row. And as long as I'm physically able to pick up a pen and write a letter B, I'm going to get letters that look roughly the same. Slightly different, but roughly the same. That is called common cause variation. Kristen, next slide. Special cause variation, on the other hand, is an unnatural variation that is due to something that is unexpected or not typical. And so when you look at your process, you have to think about, is what I'm seeing a common cause variation or a special cause variation? And a special cause variation, it means that something unexpected happened. And so when you have a special cause variation, you have to think about, is this something that's a one-time event and if we just ignore it, it'll go away? Or is it something that we need to address before we can move forward? Because you cannot move a process if you have a lot of special cause variation. So in this, I have written 8 B's, capital letter B's again, but you can see very clearly that one of them looks way different than the others. So you could probably guess that what happened is that I wrote that letter B with my left hand. So that is special cause variation. You can tell that the other 7 were written by the same person, by the same hand, and the 8th letter, so the 3rd letter from the left, there's something really different about it. So the special cause there was I wrote it with my left hand. Next slide, Kristen, please. So let's think about this for healthcare visits, okay? So an example I had here was we want to lower the percentage of our emergency room visits that are non-emergent. Okay, so you have to determine whether you have common or special cause variation. And the way to do that is that you have to collect on-time, ongoing data. So earlier in this call, one thing that was mentioned was run charts. Run charts on a weekly or monthly basis is an excellent way to tell whether you have special cause variation or common cause variation. So let's take emergency room visits, for example. It may not surprise folks to think about, you might have a spike in emergency room visits from your practice on a holiday, and that's because your office is closed, and if there is a problem, then the child will go to the emergency room after, or you may direct that your child and patient will go to the emergency room. So if you see spikes in emergency room visits during holidays, you would look at that and say, well, this is special cause variation. On the other hand, if you have emergency room visits that are generally just high regardless of the day of the week, regardless of the time of the year, that is common cause variation, and that's the way the process is just in general. And so your approaches to that is going to be very different. If you have spikes in emergency room use, you have to address the spikes. On the other hand, if your emergency room use is generally high, then you have to address the entire process, and that might go into things like access, that might go into things like general outreach to patients, hours. Your process for addressing those things are going to be different. But again, in order to figure that out, you have to have the data necessary to help you understand whether you have a special cause or a common cause variation. And for that, you need real-time data, if possible, and you need ongoing data collection. And those are things that if you either have experience, would like to share some of it, or if you are looking to address your process and would like help, that is where we can definitely come in and talk to you all more about that one-on-one. Kristen, next slide, please. So what's next is that when you look at a metric and you want to figure out whether it is under control or not under control, you need real-time data. And the data does not have to be particularly sophisticated. You can do chart audits, you can get real-time alerts, you can talk to hospitals about sending you information about the patients that are admitted, and you just keep track of it in an Excel spreadsheet. But the bottom line is that data collected on a real-time basis will help you be able to move that metric from one to another. Once you collect some baseline data, never react to data that you collect initially because it could be a special cause variation. You have to collect several rounds of data, let's say 6 to 8 weeks, before you can really say, all right, I've got a special cause variation or I've got a common cause variation. If you have a special cause variation, you have to address the special cause issue. If you have a common cause variation, that means you have a stable process, but you need to move the entire process to be able to get your adolescent visit rate up, to get your non-emergent rate down, in which case it's time for PDSA cycles to try to address the process. Always use data to help you because you need data to be able to tell where you are and where you're going. And we are very, very happy to help talk with you all to be able to walk you all through this process. This is a very powerful way of moving your process to be able to meet a metric if when you're trying to go from one metric standard to another. Kristen, next slide.
Dennis?
Yes, sir.
Hey, Dr. Patton, sorry to interrupt, but who exactly is we? When you say we, ready to help.
Okay, so when I say we, I'm referring to us at the AAP. So, you know, you've got us at the executive committee. You know, I've got a fair amount of quality improvement training experience. You know, we've run those 2 learning collaboratives for asthma. So we've got a lot of experiences just walking through processes and thinking about data. And between that and knowing the metrics, you know, that's when we can help. So we means me, Kristen, and our executive committee, and Amy Ollinghouse, our executive director.
Okay, thank you.
Sure. Other questions? Open mic time. Are there other reactions or thoughts or observations on PCMH that we'd like to go over today while we have the time?
Well, this is Dr. Patton. I have a ton of questions, but I don't want to dominate the discussion, so I'm going to wait and see if someone else has one.
Okay. Dr. Patton, I think you're good to go ahead.
All right. Let's see. I was making a few notes while you were speaking. Back to one of the quality care metrics for the office. Let's see. Under the appropriate medications for asthma, I think I know the answer to that, but I'm not sure that I've ever seen a definition on what's appropriate medication. Okay.
I can send you the exact definition for that. There's a HEDIS measure that pertains to it, and it actually ends up being if there's a claim for, you know, if you have a diagnosis of asthma and had a number of visits that denotes chronic use, they're looking for any sort of preventive medication, and that goes anything from inhaled corticosteroids to the leukotriene inhibitors, even cromoline's on there. Not that I'm sure most of us aren't really using cromoline regularly anymore, but it's actually pretty broad.
Okay. So it's basically use of controller medications in kids that seem to be recurrent.
Yes.
Okay.
What else do you have? Other questions?
Fine, got that. Got that. Okay. The PCP visits for high-profile beneficiaries, I believe that's just defined as 2 per year. Is that correct?
That's correct.
Okay. You answered the 10-day follow-up. Now, I am a little confused about the non-emergency ED visits. I know that in general the goal is to see non-emergent cases in the office, not in the ED, so I understand that. But the last comment you made about the common variation, my perception is that our non-emergent ED visits are high, but yet our report does not indicate that. We met the criteria this last year, but just my subjective observation is they're high. Can you tell me more about how that's determined?
I can. There is an algorithm that was developed. It's called the NYU ED algorithm, and I've actually, if you want all the details, I can actually send you that spreadsheet. But what they did was they've categorized all of the ICD-9 codes, and they've through panels over a period of time, they rank what percentage of each of those codes ends up being emergent, non-emergent, emergent but emergent but can be handled within 12 hours in a primary care office, and there's several categories. And what they do is distribute how many of those percentages end up being non-emergent. There are some visits that end up being 100%. For example, kind of pull this up. They end up being something like 100% non-emergent, and then you've got things like strep pharyngitis, which a percentage is considered non-emergent. But there's an algorithm, and I agree with you that I think that the algorithm actually ends up being overly optimistic as to what we in primary care can keep out of the emergency room. But it is a metric, and as a standard, it does give us something to look at. And I'd be happy to share. I do have a copy of that algorithm. You can see what exactly is on that algorithm. I do think, however, that even though we even if we feel that we are meeting an algorithm, we are meeting a metric, that doesn't mean that we can't change. We can't continue to make improvements in that metric. I think that we all can look at our patient panels and say, we know that we can always do more to try to keep our kids in the primary care office. And I certainly would not discourage folks from addressing that issue if they feel that there's something more that they can do, regardless of how we are in that metric.
Okay, thanks very much.
Sure.
This is Cheryl Arnold again. I have just one question and one comment.
Sure.
The question is, last time I checked, AHIN did not have our updated panel available. Does anyone know when that's going to be available for us to identify our 2015 high priority beneficiaries?
Yeah, the last I heard was early March, and that has been, if anyone has any other information about that, I'm interested, but that's the last I had heard. I do think that that's roughly the time that we got it last year, and some discussion we had was there any way we can get it earlier than early March because of the amount of time that we needed in order to get the HPB list submitted. Does anyone else have any additional information other than that?
Dr. Quata, this is Amelia at AFMC. We actually have a meeting today with PCMH, and we will confirm and get word back to you as to when they anticipate having that up and ready to go.
Thanks, I appreciate it. I think any update you have on that would be very helpful for us. Okay,
we'll let you know.
Cheryl, back to you. You have another comment or question?
Well, I was just going to share with the group, and I'm not sure how many practices are on the call, but we did have our audit process for our care plans, at least had to prepare the information for that last week. And I have signed up with AFMC for practice transformation support, and I did communicate some of the, I guess, weaknesses of the process that I identified to Belinda in hopes that those could maybe be passed along. And for the other practices that haven't had their charts requested yet, and I know one of them has already been changed in that I was just provided a list by Medicaid number, which we can't pull patients from our system by Medicaid number only, and you can't pull them up for coverage verification by number only. So we had to call Medicaid to get the names of the patients that we were supposed to prepare the charts on. And you had a 48-hour window from the time you were notified until they were here to pick up the charts. It took us half a day. We had 40 charts we had to do, 5 per provider.
Right.
So it's a pretty time-consuming process, so when you get that notification, I would suggest you get to work on it immediately because that 48 hours will evaporate rather quickly. The other thing that was frustrating to me, and this, excuse me for a soapbox here, but so much of the patient-centered medical home issues are encouraging all the practices to do more and more electronically, share electronic prescribing, EMR, secure texting, all of these things that we have all been working on for the past anywhere, 8 to 10 or 15 years, getting more electronic. And then for this review, we had to print every single thing out. And, we couldn't provide it in electronic format for the chart audit. So that's my 2 cents and I was told we were the first clinic to have our charts requested. So that's my experience.
Cheryl, I appreciate you sharing the experience. I definitely would like Kristen and us to follow up with you a little further on that, just to kind of, just so we want to make sure that all of our practices are prepared. I really appreciate that. Are there any comments or other observations or kind of experiences that folks want to share? Okay, Cheryl, we'll definitely follow up with you on that. I appreciate your comments. Anything else before we close?
Just to remind everyone, if you have any difficulties, please contact me with any questions. And also, we have a feedback form that you can fill out located on our website. And I think almost everyone's signed up for listserv, but just in case you haven't, this is the link. And I'll be sending out these slides to everyone. And you can also see this webinar if you go to our website.
Okay, thanks everybody.
Thank you.
Okay, y'all have a great day. Bye-bye.